Okay, and so today's video we're going to talk about three dermatologically related conditions. The first one being erythema multiforme or multiform, and the other two being Stevens-Johnson syndrome and toxic epidermal necrolysis, and it's written as the acronym TEN for short. And these both are also just kind of called epidermal necrolysis as well. So a lot of names here. These three conditions are pretty much just a spectrum of the same pathology, and that's kind of what's theorized. And so erythema multiforme is the mildest form, and then Stevens-Johnson syndrome is going to be, I guess you can say, the second mildest, and then toxic epidermal necrolysis is the most severe form. So the way we'll do this is we will tackle erythema multiforme alone, and then we'll talk about Stevens-Johnson syndrome and toxic epidermal necrolysis together. Okay, so let's first start the topic here with erythema multiforme. So what is this? This is a very characteristic rash, and it actually is kind of mimicked by many other rashes, but it has this very characteristic target shaped lesion. And so what it looks like is you have a central kind of erythematous zone, and then right around it you have another ring of erythematous zone as well. So so this is the characteristic lesion, but of course it doesn't always look like that. Sometimes it can be mistaken for urticaria. So in urticaria, you know, say in the beginning you don't have this middle area here, it'll look just like a wheel. So, but the way you would differentiate it from urticaria and erythema multiforme is urticaria kind of goes away after 24 hours, whereas erythema multiforme will stay much longer. And again, the reason why it's called multiforme is because it can have many forms. So it can range from, just a macular rash to more of a larger papular rash, vesicles, and even bullae. So you have a lot of different forms that it can come in, but the characteristic lesion is this target-shaped rash. So if this target-shaped rash, you definitely know this is what you're dealing with. Okay, so let's talk about clinically, what do you look for? In this situation, history does become important. It is, first of all, they will not have any prodromal symptoms. That's very rare to have any prodromal symptoms, so they won't be like complaining of a fever or previous fever or rash or sore throat or anything like that. But they do have fever. The prodromal symptoms that they won't have will be like a cough or sore throat, or anything like that. Here they do have a fever that's usually greater than 38.5 degrees Celsius, so fairly high fever. And the other thing is if there's a history of prior attacks, usually 1/3 of people will have a history of prior attacks. So this is also something that can lead you more towards a diagnosis of erythema multiforme. So let's talk about the actual lesion that you would see. The lesion, like we kind of described earlier, is the target-shaped rash. Let's actually start here. So the lesion, first of all, where do you get it? Generally the face and extremities. This is the most common. You can also get on the trunk as well, but the most common is going to be face and extremities. And so what you can see here, this is the best one here. You can see the kind of center circle there, and then the outer target-shaped lesion. And as you can see here, the central piece isn't there, so it can kind of look like a wheel when that central erythema isn't there. The other thing that's interesting about the lesion is, with regards to its location, is it does kind of follow the Koebner phenomenon, and the Koebner phenomenon just kind of says that wherever there is a lot of traction, that it tends to occur there more often. Also, it has the actinic phenomenon, which just means that it falls into sun-exposed areas. Another thing, before we go into the mucosal sites, is sometimes the central area can blister, and so you can get if you can see here, you have this area that's actually blistering. So the central erythematous zone can blister. So that's another feature that is associated with this. There's a cutaneous lesion, but there's also a mucocutaneous lesion as well. And this generally is on the lips, either on the outside of the lips or on the inside of the lips, and it tends to this doesn't have the characteristic target-shaped rash. You get this type of diffuse type of rash that you see here. And again, it can happen on both sides. It can even go down to the throat, esophagus, and even to the trachea. So, and if it happens on the outside, you can actually the lips can look like huge blisters on top of it. So that's also there as well. Excuse me. So, what is the course? Generally, it's a mild course. They usually have symptoms for 2 weeks, and then you have resolution, and then they'll be fine. Usually, there's no lasting sequelae. The biggest problem with this is it does recur. It's very common for it to recur. So let's talk about what actually causes this. What actually causes this? The main causative factor is herpes simplex virus. Herpes simplex virus, labialis or genitalis, it has been associated with about 60% of these. So very, very common to get herpes simplex virus associated with these. The second thing is going to be mycoplasma. And so when you suspect this, they usually have some type of lower respiratory tract symptoms. And also, finally, drugs, even though it's a little bit rare, but there are some times where drugs can't have it. And actually, these are usually imitators. So they imitate Erythema multiforme, but it's not actually Erythema multiforme. It's just another type of skin rash. So actually, I should say that drug is not a causative factor. It just sometimes imitates Erythema multiforme. So now, how would you manage a patient with Erythema multiforme? So management, primarily it's going to be supportive, but let's just talk about what you do first. So the first step in management is you'd have to suspect it. And there's certain features, so you have to suspect Erythema multiforme. So there's certain features which will kind of have you lean towards have it being Erythema multiforme, and then certain against. So of course, if it's a target-shaped lesion, that's a big plus there. If it's recurrent, so they had a previous incident with this, because remember herpes simplex, it lays dormant in the dorsal root ganglion and it comes back. So whenever it comes back, you get this recurrent thing. If it involves a mucus, and if it's in like more of an acral type of pattern, then what is going to be against it? If it's transient will you probably want to think more along the lines of urticaria, wheals. If it's widespread, if it's throughout the whole body, that's kind of not consistent with Erythema multiforme. And if you have a type of subacute evolution. Okay, so this will kind of after this, you can try to figure out whether it's Erythema multiforme or not. The second step is you want to determine if hospitalization is necessary. So determine whether this patient needs to be hospitalized or not. So what are things that will make you want to consider hospitalization? The first thing is if they have impaired feeding. So if they're not able to feed themselves, then you definitely want to hospitalize them and monitor them. Secondly, if it can possibly be a Stevens-Johnson syndrome. So if they show any signs of that, you probably want to hospitalize before it gets any worse. And finally, you do, if they have constitutional symptoms, you would be worried as well. After that, you're going to try to figure out the cause, whether it's herpes simplex virus. So if it's herpes simplex virus, you can do oftentimes serology. You can't try to actually get a swab from the actual lesion. Sometimes you get it, sometimes you can't, but you can't necessarily rule it out. Chest x-ray, because remember mycoplasma can be associated with that. And then, if you do want to test for mycoplasma, you can do a PCR assay of a throat swab, or you can just do serology. So those are the two things there. Now, how would you treat it? Actual treatment of it is supportive. So you're going to primarily have supportive treatment. And first you want to give an antipyretic if they have a fever, because that's not nice to have. And then you want to try to treat the actual lesion with a topical emollient. So again, this is just a symptomatic type of treatment. You can also give NSAIDs to help them out, or even antihistamines to try to relieve some of the symptoms. And if you find out it's herpes simplex virus, you can give oral cyclovir, and if you find out if it's mycoplasma, you can give appropriate antibiotics. One thing you do not want to give is glucocorticoids. Although it makes them symptomatically better, it's actually been shown that it kind of elongates the duration of the disease, and it can actually increase complications, because again, herpes simplex virus will then proliferate even further. So glucocorticoids, it's no longer recommended, so cancel that. No prednisone, anything like that. And so usually what happens, I guess just the course of it, after 1 to 4 weeks, usually resolves. There's no sequelae, but it is recurrent sometimes up to 10 years. So for 10 years they'll be battling this, and they said even sometimes there's over 50 recurrences before the patient actually gets rid of this condition. So that is erythema multiforme. Again, it doesn't really cause too much trouble. It doesn't become Stevens-Johnson syndrome or toxic epidermal necrolysis, and it's just something that they have to deal with on a chronic level. So let's talk about something that is more acute, and it does cause a lot of problems, which is going to be what's going on here? Okay, so this is going to be epidermal necrolysis. Okay, so epidermal necrolysis is divided into two categories, actually 3 categories, based on severity. The first one is going to be if it's Stevens-Johnson syndrome. So Stevens-Johnson syndrome is defined by involvement of less than 10% of the body surface area. Then there is Stevens-Johnson syndrome, toxic epidermal necrolysis overlap. And this is defined by involving 10 to 30% of the body surface area. And finally, you have full-blown toxic epidermal necrolysis, which is greater than 30% of the body surface area. And this is associated with the mortality. So generally when the patient has TEN, the mortality is around 20%. Whereas if it's just Stevens-Johnson syndrome, it's going to be anywhere from 5 to 12%. So as the severity increases and there's more body surface area involved, there is definitely going to be more higher rate of mortality. So what causes this condition, which by now you should see does have a significant mortality, is drugs. This is over 100 drugs are implicated, but there is about a dozen which are high-risk drugs. So generally you want to focus on the high-risk drugs. This is generally what comes up, but again, don't think that only these cause it. There are definitely a lot of drugs that cause it. So high risk, the first on the list is sulfonamides, in particular the antibiotics. Then we have the anticonvulsants, the aromatic ones. This is associated with it. Allopurinol is also one of the drugs that are high risk for this. NSAIDs, and going on to the anticonvulsants, lamotrigine and nevirapine. So this is the current list that I have, but again, there's many more. Also, on top of these drugs, there are other conditions that are associated with it. Viral infections are associated with immunization, can be associated with it. Mycoplasma, and this is kind of overlaps with EM, erythema multiforme, and finally graft versus host disease. So patients with bone marrow can sometimes experience this type of treatment. Now here's the other thing that, before I move on. Generally, the drug will be given 8 weeks prior. So 2 months prior, they will have they will have it. 2 months later, after receiving the drug, they will have these symptoms. So it is kind of a long time. Now, so let's talk about from the clinical aspect, because I've already talked about the duration. Let's talk about how does this play out. Well, generally, 8 weeks. They'll take a drug. 8 weeks, they'll be okay. Then what will happen is they'll start the skin will start peeling off. So it's going to end up undergoing necrolysis. For about 5 to 7 days, it'll increase. Then it'll reach a plateau phase. And this plateau phase can last days to weeks. And this is when all the life-threatening symptoms occur, complications occur, such as sepsis, multi-organ failure, and it's very similar to burns. And when we talk about treatment, it gets treated very similar to how burn patients get treated, because just like in burn patients, they're just losing a lot of skin. And so this is when this plateau phase is when all of the complications start to begin to be seen. So how does it start? The first thing that you're going to get, you will get prodromal symptoms. So you will get the constitutional, the headaches, the rhinitis, of course fever. You will get all of these, and even maybe a cough. It'll sometimes it starts off as a cough, and then you start getting the cutaneous lesions. So the first thing you'll get generally is the cutaneous lesion, but it can start with mucocutaneous as well. It generally starts in the face, goes to the upper trunk, and then the upper limbs. And so what's happening in the cutaneous is the skin is actually peeling off, and it does look very similar to a burns patient. So here we have a child here who's unfortunately had this condition. So you can see this area right here, and over here, this is where the skin has completely peeled off. And so it starts in that upper trunk. It started probably in the face, went up to the upper trunk, upper arms, and it's actually continuing all the way down to the body. And again, depending on how much surface area it covers, we categorize it into one of those categories over there. So that's generally where it starts, and it continues throughout the whole body. So some things about the actual lesions. They start off as erythematous, so they start off with just general redness, macules. And then they will come together. So then they will kind of become confluent. So you can see that eventually, these two will come together there. The other thing is it's going to have something called Nikolsky sign. And so what this means is in areas where it's red, you can actually just rub off the skin. And so you can just imagine here, right next to these areas, in this over here, if you just kind of use your finger and just kind of start rubbing it, the skin would come off. And so it breaks very easily with pressure. And so this is this is a big sign that you're dealing with epidermal necrolysis, or Stevens-Johnson syndrome, or TEN. Now, that's the cutaneous lesion. You can also get mucocutaneous lesions. And so this is generally going to be in the mouth and esophagus and trachea. What will happen first is you're going to have pain on swelling. And so this is the pain on swallowing. So this is the first symptom that something is going wrong, and then you can even have eye pain. And so this is usually how the mucus lesion starts. So once you have this swelling and eye pain, then the symptoms will just kind of erupt after that. So those are your cutaneous symptoms, mucocutaneous. You do have significant amount of extracutaneous symptoms. And these are associated with a lot of complications as well. Of course, we mentioned the prodromal symptoms such as fever, pain, and weakness. This is there, kind of the constitutional symptoms related to it. The main one is going to be pulmonary. 25% of the time it is associated with pulmonary symptoms, and this is the most serious complication that we have to worry about. So associated with increased respiratory rate, cough, and oftentimes you can kind of go down to ARDS, and you can also get some of the chronic lung conditions, bronchiectasis, and all those. So chronic lung disease is associated, even after the initial acute phase is over. The second type of extracutaneous is going to be GIT. So what you can think of is not only is it affecting the skin on the outside, it's affecting the skin on the inside. So you start to get necrosis of the esophagus, all the way to the small intestines, all the way to the colon. So pretty much the entire GIT tract is involved. And so symptomatically, you're going to get diarrhea, malabsorption is also prevalent, and even melena. And melena is just when you have blood in the stool, but it becomes black and tarry, not necessarily looks like outright stool there. So and this can actually have an impact on the mouth as well. And you can have a complication where they actually can no longer taste, so taste is gone, and they can even have it can alter their teeth pattern. So this is very, very significant effect on the GIT, as you can see. You can even have renal problems, and this can lead to the increased urea, which is one of the things that we look for when we're working up a patient. It can even affect the nails, so along with the skin, it can affect the nails, even removing the nail completely, anonychia, and even ridging of the nails. So it has been shown with that. It can even affect the genitalia. So the vulva and vagina are affected, and they can be affected up to 25% of the time. So it's very, very significant. It's been associated with dyspareunia, and so what's happening is once they have this Stevens-Johnson syndrome, they have vaginal dryness, itching, and painful bleeding, and this makes it painful whenever they have intercourse. And finally, one of the biggest issues as well is the optic. You can have symptoms that are related to the eye, and basically what happens is you have chronic inflammation, and this can lead to fibrosis of the eye, and you can even have entropion, where the eyelid actually folds in, and this is kind of the scarring and fibrosis due to the severity of the disease. You can even have trichiasis, where the hair in the eye goes inwards, and you can get semblefin as well. And then actually, and this is why you want to, this can actually happen up to 1 year later. So this can happen 1 year later. And so this is why when someone does experience a case of Stevens-Johnson syndrome, you want to kind of monitor them even afterwards and make sure they're not developing any of these future complications. Okay, so prognosis. Let's talk about prognosis here. There is a prognosis type of scoring system, which is called the Score 10. Score 10. So that's how it's spelled. A little incorrectly, but that's what they decided to do. And so with this Score 10, what they have is they have different features, such as if their age is greater than 40, if their heart rate is greater than 120, if they have an associating cancer with it, if the body surface area involved is greater than 10%, if their urea is elevated more than 20 millimolars, if they have elevated bicarb, or if they have elevated glucose more than 14 millimolars. They get a point for each one, so you can get, so depending on how much they have, they get 1 point, so they can get a total of 7 points. Now, generally to have 0 to 1 point, there's about a 3.2% mortality associated with that, but if they have greater than 5 points, it's a 90% mortality. So huge difference when you have all of these underlying features, and so this definitely helps guide how vigorously you want to treat the patient. So let's talk about workup. How would you work up a patient? So let's go into management. The first thing that you want to do when you get a patient with Stevens-Johnson syndrome or toxic epidermal necrolysis is you want to look at the respiratory rate, because remember, it can affect the breathing, the lungs. So you want to pay attention to the respiratory rate. You want to check oxygen, and you want to do arterial blood gases right away. Then what you want to do is you want to start doing lab work. The first thing you want to check out is glucose, and glucose will be elevated when they become into a hypercatabolic state. So when that occurs, the body decreases the amount of insulin produces, and it just starts making energy. So that's why you'll see this elevated. You also want to check the urea, because this will give you a sign of how the kidneys function, and bicarb. And so bicarb, you're measuring this because, of course, their breathing is affected, and so that's going to affect the breathing as well. So so this is the kind of, I guess, the initial lab work you want to do. What is the initial treatment you want to do? The biggest life-saving factor is to identify the drug and stop the drugs. Stop whatever is causing this as soon as possible. So you want to review with them in the past 8 weeks what drugs, any new drugs that they started, and try to stop them right away. Next, you want to admit to the ICU or the burns ward, And again, just like with burns, you want to give fluids. You don't need to give the same amount of fluids as with burns because you don't have, it's not as bad, but you want to give a lot of fluid and you want to give a lot of electrolytes. Because without the skin, you're just losing all the fluid right through the skin. So the second you want to give an NG tube, you want to make sure they're feeding well. There's kind of an issue of debridement, whether you want to debride or not. It's kind of controversial. There's people on both sides, so I guess it's just controversial at the moment. If they have any infection, then you want to give antibiotics for that. That's definitely a good idea. And speaking of that, also you want to have their mouth rinsed with antiseptic wash every day, just to protect them from getting any type of infections in the mouth. For the eye, because remember the eye has a lot of complications, it needs to be checked daily. You probably want to give some emollients, some topical antibiotic as a drop, and you also want to give vitamin A every 2 hours to protect the eye in the acute phase. Then finally, you want to give them, some medications. At the end of the day, this is an autoimmune reaction. The drug is causing the hypersensitivity reaction to the body, and so you want to shut down pretty much the immune system, at least temporarily. So give corticosteroids. IVIG also works. Cyclosporin is also another option. And the other thing you can do is you can give plasmapheresis, because the idea is that there's some plasmapheresis or hemodialysis, and the idea is that there's some agent that's in the blood which is causing all these symptoms. So by doing plasmapheresis or hemodialysis, you're going to be able to remove that, clear the body of that type of offending agent right away.